Psychological disorders. DSM-5 refers to a psychological disorder as a dysfunction within an individual associated with impairment, distress, and functioning in response that is not typical. This impacts behavior, how a person thinks, feels, and acts. There are different categories of psychological disorders such as mood disorders, personality disorders, psychotic disorders, and anxiety disorders, which I will delve into later. The Diagnostic and Statistical Manual of Mental Health Disorders, also known as DSM, is a manual published by the American Psychiatric Association that provides the criteria required for diagnosing psychological disorders. DSM is updated every now and then, and it is now in its 5th edition, and it is referred to as DSM-5. Factors that contribute to the development of a psychological disorder. Disorders are determined by a complex exchange of psychological, biological, and environmental factors. Psychological disorders include emotional, cognitive, and behavioral factors that may interact with environmental and biological factors that will contribute to the development of a psychological disorder. Behavioral factors include how a person responds to external and internal stimulus. Cognitive factors include how a person thinks about themselves, their future, life events, and the world. Biological factors include genetic predisposition that can lead to vulnerability to developing or inheriting a disorder. Emotional factors is the ability to regulate their emotions and how they react to them. This may also include drugs, traumatic life events, social isolation, as well as stressors such as work and family, and much more. All of these factors can contribute to the development of a mental disorder. Unspecified mood disorders. Mood disorders are subdivided into two categories. The first category is in reference to only depression as their main symptom, and the second is in reference to mania accompanied with depression as their main symptom. Mood disorders are the most common type of disorders, and the National Institute of Mental Health estimates that 21.4% of adults have or had a mood disorder throughout their life. Depression. Depression is the first type of mood disorder and is characterized by having a main symptom of depression. There are many different types under this category, such as major depressive disorder, seasonal affective depression, persistent depressive disorder, premenstrual depressive disorder, etc. It is estimated that 16.6% of the population have experienced depression throughout their lives. I will mainly focus on MDD. Symptoms of MDD. MDD is episodic, which means it can last for 5 months or longer. It is characterized by sadness accompanied by loss of enjoyment in usual activities. It may also include changes in appetite, such as eating too much or too little, disturbance in sleep, such as sleeping too much or too little, lack of energy, thoughts of suicide, and in some cases, psychomotor retardation, or in other cases, agitation, feelings of worthlessness, and much more. It can also be accompanied by somatic symptoms such as back pain and stomach pain. Cause of depression. MDD is believed to be developed through the interaction of many factors, through psychological factors, biological factors such as genetics or chemical, structural differences within one's brain, and environmental factors such as traumatic life events. Stanford Medicine states that heritability of depression is 50% genetic and 50% caused by external factors such as environmental. Neurology of MDD. The main areas thought to be involved in MDD include the frontal lobes, the orbitofrontal cortex, the ventromedial prefrontal cortex, the dorsolateral prefrontal cortex, the hippocampus, the amygdala, and the anterior cingulate cortex. The ventromedial and dorsolateral cortex demonstrate opposite patterns of activity during MDD, meaning that there is hypoactivity in VLPFC and hyperactivity in the VMPFC. Hyperactivity in the VMPFC has been shown in studies to be tied to rumination, and hypoactivity in the DLPFC has been tied to apathy and psychomotor retardation. The abnormalities in the orbitofrontal cortex have been associated with irritability and anger and depressed mood. It also contributes to the maintenance of negative emotions and thoughts. Studies have found that there was overactivity within people with MDD. The amygdala is known for its contribution to stress response, and in people with MDD, higher activity was shown. Studies have found that people with MDD have a reduced volume of their hippocampus, and this is due to loss of gray matter caused by increased levels of glucocorticoids caused by the MDD, although researchers have found that once a patient was put on proper medication, the gray matter increased in size, as antidepressants play a role in nerve growth by increasing the number of proteins. Neurotransmitters. The main hypothesis regarding the relationship between neurotransmitters and MDD are that depression causes a decrease in levels of serotonin, dopamine, and norepinephrine. This is known as the monoamine hypothesis. The main medication for MDD is selective serotonin reuptake inhibitors, most commonly known as SSRIs, which prevents the reuptake of serotonin. Second main hypothesis is thought to be caused by a dysfunction in the glutaminergic neurotransmitters, which plays an important role in mood regulation, memory, and cognition. Studies have found that people with MDD had increased levels of glutaminergic neurotransmitters. The other type of mood disorders. Second type of mood disorder is mania accompanied with depression. This includes bipolar 1, bipolar 2, and cyclothymia, as well as unspecified or specified bipolar-related disorders. This type of mood disorder affects about 1 to 4% of the population. Difference between bipolar 1 and bipolar 2. Bipolar 1 is diagnosed by a distinct period of mood disturbance, specifically when a person experiences at least one manic episode following or before a depressive episode. Bipolar 2 is classified by a cycle of depression hypomania. A person with this type of diagnosis experiences hypomania, which is a less intense form of mania, although at times it may appear the same. Mania is classified by experiencing agitated moods, decreased need for sleep, inflated sense of self, increased sexual activity, risky behavior. This impacts their social life, work, and school. Mania may at times, although rarely, lead to psychosis. The cause. Bipolar is heavily associated with genetics. 80 to 90% of people diagnosed with any type of bipolar have a relative that has been diagnosed with it as well. Environmental factors also play a role in the development of this psychological disorders, such as stress, drugs, and alcohol use, as well as sleep disruptions. There has also been some studies that have found that there might be a tie to traumatic events experienced in childhood that increase the chances of developing bipolar, although the reason is still unclear according to DSM-5-TR. The neurology. Although the source of bipolar is known, the neurobiology of the disease is still mostly unknown, as well as the fact that many studies have been conducted on people with borderline personality disorder, which is hard to interpret in the context of mania. Only in recent years has there been some studies that have had a breakthrough, so everything I will be discussing is still not 100% certain, but are the most viable causes to date. Bipolar has been thought to be a progressive disease with functional decline and cognitive impairment. These impairments seem to happen after the reoccurrence of episodes. Neuroprogression seems to also affect the oxidative stress immune dysfunction, mitochondrial dysfunction, impairment in cellular resilience, and neurotrophic support breakdown. It has also been suggested that the reoccurrence of multiple episodes seem to alter permanently neuronal activity. It is important to note that these aspects of neuroprogression have not been present in all patients. The neural cause of a manic episode is still unclear, although parts of the brain have been identified. During a manic episode, there seemed to be hyperactivity in the left hemisphere and hypoactivity in the right hemisphere, specifically in the amygdala, anterior cingulate cortex in the left hemisphere, and the ventral prefrontal cortex in the right hemisphere. Studies have found using neuroimaging during a manic episode increased level in the left anterior cingulate cortex, left basal ganglia, and left amygdala, and decreased activity in the ventromedial and ventrolateral prefrontal cortices. Anxiety disorders. Anxiety disorders are identified by exaggerated levels of worry, fear, and anxiety. Anxiety is an emotional state distinguished by nervousness or worry directed at future events involving apprehension towards said events. Anxiety is a natural bodily response and everybody experiences, but in people with an anxiety disorder, their anxiety is usually exaggerated and either irrational or out of proportion in context to their situation. Although people use fear and anxiety interchangeably, the key difference is that fear is triggered by an immediate, definable threat, for example, seeing a rat and getting scared. Anxiety is linked to apprehension of future situations, such as a test. Anxiety disorders are one of the most common psychological disorders in the US, and about 21% of the adult population is affected. Anxiety disorders include panic disorders, social anxiety, phobias, agoraphobia, generalized anxiety disorder, and many more. Symptoms. According to DSM-5, anxiety disorders are characterized by excessive worry and anxiety, regularly occurring on more days than not for at least 6 months, about several activities in different situations such as work and school, as well as being easily fatigued, difficulty concentrating, clearing thoughts, and sleep disturbances, either difficulty falling asleep or staying asleep, as well as restlessness. Physiological aspects of the disorder include, but is not limited to, nausea, shortness of breath, muscle tension, dry mouth. It is important to note that these symptoms do not explain other disorders such as OCD, eating disorders, panic disorders. The cause. Researchers have found the two most prevalent factors that contribute to the development of anxiety disorders are environmental and genetic factors. Environmental factors such as being in a high-stress environment for extended periods of time, being exposed to negative environments, Genetics also play a role in the development of an anxiety disorders and are increased if a family member has also been diagnosed with an anxiety disorder. Other factors that can cause the development or aggravate anxiety disorders are substance use and/or caffeine, as well as other health conditions such as thyroid conditions or heart arrhythmias. The neurology. It is believed that dysfunction in the brain structure that processes emotions such as the amygdala, which is responsible for processing potential threats, which plays a key role in the fear circuit. Excessive activity of the amygdala has been largely observed within people with anxiety disorders. The fear circuit is a result to a stimulus that triggers a fight or flight response. It is a chain reaction that starts within the amygdala, which sends signals to the hypothalamus, which then triggers the hypothalamic pituitary adrenal axis. Within the HPA axis, the hypothalamus secretes corticotropin, which binds to receptors in the pituitary gland, resulting in the release of adrenocorticotropic hormones, which then goes to adrenal gland situated on top of the kidney, which then triggers the adrenal gland to release cortisol, which is a key hormone in the long-term stress response. Aside from the fear circuit's role with anxiety disorders, there has also been research conducted on areas responsible for anxiety, which includes the cingulate opercular network, which is thought to be responsible for detection of conflict, the ventral attention network, which is thought to be responsible for stimulus-driven attention, the default mode network, which is a network active when a person's mental activities are not focused on external stimulus, for example, thinking. The frontal-parietal network, which is believed to be responsible for cognitive control. Neurotransmitters. The neurotransmitters that are believed to play a large role in anxiety disorders is gamma-aminobutyric acid, also known as GABA, which plays a major role in the regulation of anxiety and to keep track of the amygdala's activity, which, as mentioned beforehand, is hyperactive within people with anxiety disorders. Another transmitter thought to play a major role in anxiety disorders is serotonin, which plays a role in mood regulation. Obsessive-compulsive and related disorders. Beforehand, OCD was labeled as an anxiety disorder in the DSM, but in recent years it has acquired its own category known as obsessive-compulsive and related disorders. Obsessive-compulsive disorder affects about 2% of the population at some point in their lives. OCD is a disorder characterized by repetitive behavior and intrusive or unwanted thoughts. A person with OCD will feel compelled to perform certain compulsions. Obsessions are intrusive thoughts that provoke high levels of anxiety if they are not completed properly. There are many different types of OCD, such as contamination, symmetry, health checking, and many more. These different types of OCD are characterized by a person's mean compulsion. These obsessions tend to turn into a ritualized concept in which they absolutely need to complete it to relieve their anxiety until obsessions arise again, and which they will again have to do said behavior. Symptoms. DSM-5 identifies OCD by recurring obsessive thoughts that causes distress or anxiety, in which the individual will try to diminish anxiety by participating in certain behaviors or mental acts such as praying or counting. For example, if an individual has contamination OCD and believes that they have germs on their hands, they'll continuously wash their hands until they believe they are clean. These acts tend to be irrational when compared to their beliefs. These compulsions tend to be time-consuming and affect their social life, school, and work. The cause. Studies have shown that if a close relative has been diagnosed with OCD, the chances of an individual developing OCD increases. There has been some association between people who experience childhood trauma and the development of OCD. Researchers have also found that people with OCD have abnormalities in the frontal cortex. The neurology. Abnormalities in the frontal cortex is believed to be in a functional loop that includes areas of the brain in the prefrontal cortex, such as the anterior medial prefrontal cortex, the dorsolateral prefrontal cortex, the orbital frontal cortex, as well as the basal ganglion and the thalamus, which is thought to play a major role in the symptoms of OCD. These areas are known as the CSTC model of OCD. Within people with OCD, the direct pathway of the corticostriatal thalamic cortical loop is much more active due to the GPI and SN being inhibited by the striatum. The inhibitory action on the thalamus is being stopped, which therefore leads the thalamus to be excited by the cortical regions, the orbital frontal cortex, and the anterior cingulate cortex. Another potential factor is the anterior cingulate cortex, which has been linked with anxiety disorders. The ACC creates exaggerated error signals, which with people with OCD makes them feel like there is something constantly wrong, which may lead to obsession. Neurotransmitters. Researchers found that people with OCD had fewer serotonin receptors on postsynaptic neurons in their frontal lobe, parietal and temporal cortices, and cingulate cortex. They have also found increased activity of dopamine in the basal ganglia, which has a role in the CSTC loop, which is at the center of the cycle of OCD. It is also believed that a key factor in OCD is the lack of production of serotonin, which causes a lack of inhibition in the basal ganglia, which is already overactive due to the overproduction of dopamine. Thank you.